Thank you very much. I'm glad to be here. So today we're going to talk about using simulation to develop practice-ready practitioners. And as Gwen alluded to before, that also includes reflective practitioners. And what we just saw, and I'm going to circle back to this amazing panel that we just heard, because what they just did was reflective practitioner. Did you hear Dr. Palm say, I thought this, and now I realize this? That's an amazing reflective practitioner who is able to do that. And so we're going to talk about teamwork. And one of the things that I was impressed with the work that they just described, and you can tell this is a complex issue. And then you can go on and say they are very passionate about solving it. So one of the things I think we have to look at is who else is not at the table yet to discuss this problem. And I wrote down a whole list of people. Now these people may very well be at their tables behind the scenes. But I'm just thinking, we need to think outside the box of what needs to happen. But what they described addresses all the QSEN competencies: teamwork, collaboration, patient safety, and you just go on evidence-based practice because they talked about the evidence as well. But if you think about, we need the pharmacists at the table, in addition to the prescribers. And the legislative is already there. Emergency services, first, the recovery peer specialists. Did you see how key they were to this whole process? And then this patient and their family, and then the patient educators and the nurses, and social work and mental health and PT and OT if you're going to manage pain differently. How can we do that? And so you just looked at this and you thought, it's so impressive the work that they're doing and the impact that they are making. That is teamwork, and that's important. That's an interprofessional team. That's what we have to do, because we cannot be lone rangers out there and solve the problems that are out there. They're too complex. We need the team to do this. And I'm impressed with this work that's going on in Florida, and they're making such a huge difference here. But I just thought this whole idea that Dr. Raymond talked about when he said we debrief every day, every week, he didn't call it debriefing, but they debriefed every week. They refine their practice treatment. That is how they're going to solve this. It's because they're working together. That's impressive. So that is what we're trying to accomplish, from not only the learners all the way through the practitioners. This is not just learning, but it's about practicing as well. I am Breakthrough Learning. It's a systems game that we use in our students, and I'm part of their panel. The objectives here really is looking at the IPEC competencies, examining simulation-based learning as well, and also discussing debriefing interprofessional teams. Now, you can tell already that Terry and Roberta and team have created such an amazing day that any one group could talk all day long. And so I only have less than an hour. So I'm going to do the best I can to give you everything I can to make you think differently about this, okay? So interprofessional education, we know this definition, learning from, with, and about each other. The thing that's interesting is the Canada group had this definition almost verbatim in 2002, but we often attribute it to the WHO in 2010. Nevertheless, that is it. Now, we think we're doing interprofessional education when we put people together in the same room and they're learning pharmacology. That is parallel play. We need interprofessional education is when they are immersed in learning from and with and about each other. And that is the definition of it, and you can't define it any other way, and I'm going to talk about how we do that. So we know these National Academy publications, 1999 to Err is Human. You would think in 2018 we could just set that aside and say, wasn't that an amazing era we had and we made a difference? We still have problems. Then there's this other book that says we need to measure interprofessional education and really talk about it in patient outcomes. It's not enough. So just like simulation, interprofessional education is a methodology. It is a strategy to get to what we need. The real difference is patient outcomes. So there is a diagram out of this book, the orange one, that these are both free downloads from the National Academies, is this diagram here, which I think is really powerful, that we think about interprofessional education as what we need to do in pre-licensure. And we do, but we need to introduce it. And then we need to grow it in graduate practice. And then we need to actually make it really span out in actual practice. So I am privileged working with our hospital in interprofessional training with practitioners. And that is a real powerful place of work. And you can also examine this. This is really, we could talk a lot about this, but this is a really powerful slide that looks at some of the issues that we have around how do we move this work of interprofessional education to patient outcomes. So, nurses are the most trusted profession by the Gallup poll year after year, except when the Twin Towers went down and the firefighters were above us, as they should have been. And the next year we back up this most trusted. Right behind us is physicians and pharmacists. And they sometimes flip who's next in the queue. But the idea is that in reality, we are trusted professions. With that comes a huge responsibility. People trust us. So we have to live up to that trust. We're not. And so we need to figure out how can we help the next generation of people do that. We do it at many levels day to day, but we're still having issues where we're having patient harm. And so those people trusted us, but yet we have harm. And we have to figure it out. So when we all are living up to this trusted place, then that's what really matters. So we don't have any harm. Zero harm is what we're going towards. It will be a long time, and there's many complexity, and Gwen set us up very nicely talking about the complexity of all of that. But just because it's complex doesn't mean we couldn't still keep moving towards it. If you go back to the Sentinel events, what is the most common cause? It is communication. So like still somewhere around 60 to 80% of all errors are because of communication. That's been decades. If we could change that even a little bit, and it's only 30%, how many people would we save? So why are we not able to figure it out? We're smart people. Why can we not figure out how to do this differently? So we have to think about it differently. When we think about who's in the room, and I just have medicine, nursing, and pharmacy, and there's many other professionals, but you look at how many years of education we have. All that expertise is being brought to bear around the care of this patient and or their family. So you have medicine with 11 to 16 years, pharmacy 6 to 8 years, nursing 2 to 12 years. So we have a ton of education expertise in the room. Sometimes I think that we forget that we have other experts in the room. And we keep thinking that it's all about me. Isn't that a scary place to think that it's up to you to talk about this? So when we're training in our interprofessional course, the medical students have this real fear that it is about, I have to make all the decisions. And we say, it's about your team. And you have experts in the room who can help you. And we need to remember to call upon them. And so there's a relief in knowing that you have people there to help you. So we all have been a part of simulation-based learning. So we're going to quickly look at this video. Many of you may have seen it, but it's about CPR. I'm using this video to also debrief a facilitator, okay, because there's a lot of things happening here. So they start doing CPR and trying to get this idea that you can actually do CPR in a way that matters.
Go ahead. Where are they? You know what? If we come across somebody with no arms or legs, do we bother resuscitating? We're
talking about mannequins here.
I would want to live with no. Now, Kevin, you don't do anything.
All right, well, let's get back to it, because you're losing them.
Right. So she starts out
too fast. Everyone, we need to pump at a pace of 100 beats per minute.
Okay, that's hard to keep track. How many is that per hour?
How's that gonna help me?
I will divide and then count to it.
Okay, well, a good trick is to come to the tune of Staying Alive by the Bee Gees. Do you know that song?
Yes, I do. I love that song. First I was afraid.
Staying alive, staying alive.
You were in the parking lot earlier. That's how I know you.
Facilitator's beginning to lose it.
Staying alive, staying alive. Staying alive, staying alive. You can't tell by the way I use
You see her look? So to debrief this simulation, we need to talk to them. Thank you. That we really need to talk to them about where did you begin to lose this group, right? And how can we bring them back to the task at hand? And we can do that work. There's a whole nother session about facilitation and how to do that well. But I'm struck by her like, oh my gosh, I just want to be anywhere but here. So in healthcare simulation, we have task trainers, and there's good purposes for those. And then we have bring them to body parts, which is the torso, and then we take them to full mannequins, and also then to real life patients. So there's really logic in doing this deliberate practice of learn the skill, apply it in this context, and all those pieces. And we do a really good job of that across all of our education programs. Where we fail is put it in the context of team, right? We get you trained as a nurse or a physician or pharmacist or OT or PT, but we don't put it in the team. We know that there's many ways to use patients, and we have standardized patients that you can work with. They can be virtual, or they can actually be real patients that you do a disaster or mental health or any kind of simulation that you want to do. Just an aside, the Association for Standardized Patients just now did a standard about that so that you can get that about how the best practices in that work. Then there's also these virtual spaces that we can enter and encounter, and you're seeing Shadows Health out there and their work and what they're doing with those encounters as well. But you know, it does come back from see one, teach one, do one. That's how we used to do it, right? Or do one, teach one. So we used to do that, and that was our old way of teaching. But now we have so many different ways of doing this. So instead of just see one and do one, which is what we have here, we now have the capability of training on a task trainer, moving to it in the context of the care that's going to be delivered, taking it to the team, so that now in actuality, when we do this, we can actually be much more confident in the procedure. So we're still doing it as an individual, but we're surrounded by the team. And that's why you develop simulation in an interprofessional way. That's why it matters. So David Gaba, and this is a picture of him, definition of simulation is still one that I really like a lot. And he talks about simulation as a technique, not a technology, to replace or amplify real experiences with guided experiences that evoke or replicate sustained aspects of the real world in a fully interactive manner. That makes sense, doesn't it? That's it. So we have teams of experts. Over here on the left, you can see everybody's got their opinion. I want to lead. I know it's me, it's me, it's me, or expert teams. So we want to train to expert teams. So let's look at the expert team. I wish that we could be this good, but let's watch it. I'm going to talk to you a couple of times about this video. So this video is showing an expert team. Notice how everybody's in place. They're anticipating and they're ready for what's getting ready to happen. In fact, removing debris out of the way. They're ready. They're like, it's coming. The car is coming. (1001, 1002, 1003, 1004). Out. Watch it one more time. So this is their day-to-day job. They didn't high-five and say, awesome, we were out in 4 seconds. This is what they do. So we're going to watch it as they come back and do it one more time. Well, the point is everybody was ready. We didn't have to say, now you do this and you do this. They were well-trained and they knew what they were going to do, and they did it. And they did it efficiently in 4 seconds. Now, I know we're not cars as human beings, but can we improve our ability to rescue somebody beyond days to a few hours? How do we do that? We have to be efficient teams in order to make this work. And that's what we're really trying to do. So now, I want you to hear this clip about Billy Kimball. Many of you might have heard about his child that was born last year. So go ahead and start there. We're going to just watch a piece of this. I would say go watch it all if you can.
Tell about something that happened to our family last week. I'm sorry. I try not to get emotional, but it was a scary story. And before I go into it, I want you to know it has a happy ending, okay? So when I'm telling this, don't get too upset. Leave that to me. But a little over a week ago on Friday, April 21st, my wife, Molly, gave birth to a boy, a baby boy. His name is William Johnson. much. We call him Billy. It was an easy delivery, 6 pushes, he was out, and he appeared to be a normal, healthy baby until about 3 hours after he was born. We were out of the delivery room. We moved to the recovery room. Our whole family was there, and we introduced him to his 2.5-year-old sister. He was 2 with him. We were happy. Everything was good. My wife was in bed relaxing, and when a very attentive nurse at Cedars-Sinai Hospital, her name is Nunush, was checking him out and heard a murmur in his heart, which is common with newborn babies, but she also noticed he was a bit purple, which is not common, so she asked me to come with her, and my wife and I assumed it would be nothing. Our daughter had a heart murmur too, and we didn't notice that he wasn't the color he was supposed to be. So I accompanied Billy and the nurse, went down the hall to another part of the hospital, the neonatal ICU, where another excellent nurse named Ann checked him out and called a doctor in. And now all of a sudden it felt serious. And the room started to fill up, more doctors and nurses and equipment started coming in. And they determined he wasn't getting enough oxygen into his blood, which, as far as I understand, or understood at the time, was most likely one of 2 things, either his heart or his lungs. And you hope it's the lungs because sometimes they have fluid in them after delivery and it's potentially a minor thing. But they did an x-ray, and his lungs were fine, which meant his heart wasn't. So now more doctors and nurses and equipment come in, and it's a terrifying thing. My wife is packed in the recovery room. She has no idea what's going on. And I'm standing in the middle of a lot of very worried-looking people, kind of like right now, who are trying to figure out what the problem is. It's Friday night, and so they call a pediatric cardiologist, Dr. Evan Zahn, who, when they called him, was picking his mother up from the airport.
He goes on and tells more about the story, but at the end of the story, he pulls out a piece of paper and he names all the caregivers who care for that baby in those first few hours. And so the thing that I think is impressive, and the thing I want you to realize, is that when that baby was delivered, the team went on about their work. The obstetrician went back, delivered another baby. Everybody was doing their thing. And then all of a sudden, the team functioned at a high level. A nurse comes in and does her regular checks. Hears a murmur, sees a blue baby, activates what she needs to do. The team knows what to do. They pick that baby up. They take it to the neonatals. Validation. Sick baby. We need help. Calling the team so now everybody can come back and start helping so that the team is activated when it's needed. We don't need to all be standing around taking care of the babies. We need the people who can do this, do that, and call us when we need help. And so that's the thing that's really beautiful about high-functioning teams. You trust that they will call you when you're needed, and you will be able to do your other work, taking care of many other patients. But when you're needed, you'll be back in there. And so not only they didn't call back the other people, they called people forward of them, the pediatricians, the pediatric surgeons, and they transferred the baby, and the baby is okay. And you can hear the story, but you can tell that he noticed who made a difference, and he remembers. But sometimes we're not noticed for making a difference, and that's still okay. But the point is that we make the difference. And the thing that we notice is what's really important. The nurse noticed she had the expertise, the training, the knowledge to realize this is not normal. I need to do something about it, instead of just coming back in another few hours and the baby in distress. So we're training our practitioners to not have the knowledge, skills, and attitudes that they need. And this gets back to your question about attitudes, that we need them to know that they need to call and get help when they need it. And so how do we teach them how to do that? Because sometimes calling is like a sense of weakness, that I don't know. So I can't let you know I don't know. I'll keep struggling until I figure it out. But calling is a sign of excellence and safety, that we know when to call and we get the help that we need. So one of the things I've moved my teaching to is helping learners notice and then know what to do when they notice that something is different. So go ahead. Okay, good. So you look at this. They were using their skills to monitor and assess. They applied their expertise. And that's really, we talk in nursing a lot about caring and compassion. Caring and compassion is interpreted by our lay people out there in the world as fluffy. Anybody can do it, right? Caring and compassion is important, but true caring in practitioners is having the expertise to do what you need to do and to being able to do it when you need to do it. That's caring. And so they delegated care of the mom to somebody else. This nurse moved forward with that baby. They communicated effectively to the family and the team, and they prepared the patient for transfer, provided emotional support. They begin an essential part of the team for the patient, the parents, the family, and the whole team. Because can't you imagine, they did feel like doing high fives after they saved that baby and got him to the care that he needed. So we look at the ways that we train, and these are pictures from our simulation center where we're birthing a mannequin here. So it is Noelle, and so those who don't know Noelle, she births a baby every 8 minutes. What a woman. And so the idea here is in the gray, I have my nursing students. At the foot of the bed is a medical student who is matched for OB. And in the corner is a pediatric, a pharmacist. And beside the bed is a pediatric doc who is now matched for pediatrics. So they're in a simulation together. This is IPE. This is training, learning from, with, and about in an immersive situation. So now I'd better know what you know and what you do. Sometimes I think I have done it myself, put our learners into those roles. And we say, okay, you be the OB, and you be the respiratory therapist, and you be the pharmacist. I worry about that because then that's making our learners think, must not be that hard to be a pharmacist if I can be one. So I think we're giving the wrong message. So I wonder if we ought to have us as practitioners be the role players of those other roles and help them continue to develop in their role because they don't have any idea what the role is. And if we're saying it's that easy, then do they perceive it's not that important? What are we teaching them inadvertently? We never intended that. But I think I reconsidered that for myself. And so we have, you can see my facilitator in the back, Benny Joyner, is a colleague of mine watching this sim. We did Ebola training, as I'm sure most everybody in the nation did. And that was amazing because we brought in the practitioners and we're saying, we had an expert, William Fisher, who went to Ghana and was with Ebola patients for many months. And he came back and said, this is what you're going to see. And so when we were saying that to the practitioners, okay, we're going to have 13 liters of diarrhea a day, how we're going to manage that. And in that, they were saying, well, the rectal tubes that we have, the bags rip at 700. I said, oh, that's a problem. So I went and filled a bag full of poop and came back and said, okay, let's look at this. And when they changed it, they were worried about how do we change it and not get contaminated. So only because we were in it together, uncovering the issues, knowing what we were going to see if we were having a patient, were we able to do this. This reflection and listening, what are you most worried about as a nurse caring for an Ebola patient, given that we know that these are the things we see, then we were able to walk it through in a simulation. That was powerful. And then you're like standing here and we need to go out. How do we get out of the room? How do we bring the x-ray machine in? So then we brought radiology in. Okay, you guys come in. Let's figure out how we're going to do this. So they worked through it. So that was a powerful way to train. So we also do it in situ as well. This is Tina Willis, who is head of our sepsis code team, and that is her son who's been moulaged up to have sepsis. And when he came into the ED, they knew they were doing simulation sometime. They thought it was really her kid at first. And so they were worried that he was septic. But we actually had him as a standardized pediatric patient to do that. And then in the OR, we're doing chain training. And so we actually have cases that we do in the real OR environment with the real team so that they begin to learn how to do this together. Simulation took a giant step forward with this one study. Remember, it's one study. But it said that simulation, it was looking at simulation use, 10%, 25%, and 50%. In lieu of clinical, what was the outcomes? And they found no difference. So the no difference said, wow, we could do 50% simulation and have the same outcome as we do in clinical training. And we haven't done any research on how effective clinical training is. That's another study. But I think it's really important to realize that's really powerful statement, right? So everybody's like, oh, good, I have clinical site issues. I'm just going to do 50% sim because it's equivalent. Whoa, 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 whoa. So the National Council said, we need to do something about that, and they wrote guidelines that said you have to have training, trained personnel, right kind of equipment, et cetera, and that helps guide this. Again, it's one study, a really good study, but we need to do more studies about this too. ANAXL, I'm past president, has standards of how to do simulation. We even now have posters that you can buy and put up in your sim lab. And so you can actually get those so that you can have them up in front of everybody as you're like trying to meet the standards of care. These are the core competencies that Gwen nicely set me up for. These are free downloads as well, looking at what are the competencies we need to do in interprofessional education. They were updated in 2016. That's the right-hand side. Again, free downloads. I'm going to just give you the cue about what the updates included. So this is them looking at interprofessional teamwork and team-based practice, communication, values and ethics, and roles and responsibilities. So the updates were really moving to say, we reaffirm these are really core values. They moved them from calling them domains to competencies, and also organized them in a way that included the triple aim. And so that's the differences in those two, but get those documents and read them if you're really interested in IPE. We train, our course is based upon team steps. So earlier we talked about culture, eat strategy for breakfast, lunch, and dinner. And so what we need to realize is being able to do this means that you also have to change culture. So we can be really great at teamwork and team steps, but we also have to work at the bigger things too, how we work as a team. And that is harder than learning the skills. If there's two things that our students walk out of our school with, this is them. I want them to know what the 2 challenge rule is, that if they say, if I were going to Terry and said, I'm really worried about this patient, and I give you the reason, and Terry dismisses me, not because Terry doesn't care, because Terry has 20 competing priorities in her head. And so I haven't gotten her attention. And so then if I say it a second time and she's been trained in team steps, she now knows I've challenged her and she's more likely to hear me. And if she still, for whatever reason, can't hear me, I go above her because it's not about me and Terry. It's about the patient. And this is all done with respect and not gotcha. This is respect around this patient, okay? And that's important. So then the other is the cuss words. And many of you know this, but I am concerned, I'm uncomfortable, and this is a patient safety issue. Whatever my school did when they trained me is they made me a patient advocate. And I left there believing that I was to go change the world. And so that was a few years ago, and I have taken that to heart. But they didn't teach me how to do that. Now we can train our students to use these words and give them the language by which they can help bring about change in the advocacy of their patient. So we do these OB sims where we have the baby deliver, and this is with medicine, pharmacy, pediatrics, and nursing. So the first baby is born and is in trouble, as everybody expected, because we're doing sim. And they have to figure out what to do. So you see them in the bottom picture do a neonatal resuscitation. So our nursing students have read about it. Our medical students have been trained in it. And so it was really interesting. One of the first times we did it, our nursing students were like all around the baby in the midst of neonatal resuscitation without the skill set. And the docs were over there, learners, trying to draw up the fluid with a 22 gauge needle that was taking like a long time. And so in the debriefing, we were like, I am curious why you as a medical student were drawing up fluid. Do you do that very often? No, I had never done it before. How quick were you able to do that? Well, it took me forever, and now fluid matters in resuscitation. So then I turned to the nursing students and said, can you tell me a little bit about what you were thinking and why you were not helping get the fluids ready? Because that is your skill set. And so we began to look at operating in the full scope of our practice, and being able to do that in a team functioning makes the team move faster and better than it could without it. Then the second baby is okay, but they think we need to keep it to watch it because its APGAR was low and now we got it back up, but maybe we should keep it. And then our nursing students say we need to get it back to the mom for bonding because the baby's stable. And so you see how we set the simulations up so each profession can lead in whatever expertise that they have. So this is a bit about our course. It's an elective. It needs to be for everybody, but it's a 3-credit course. So we have 3 schools, 3 course directors. Now that seems like something you could jump over pretty quick, But you have to have the right people in this room. So when we're adding other students, you have to bring the faculty with them, because it's presumptuous if I think that I could represent the other profession as a nurse. And also those students are looking for their leader who is like them. So if you want to come and join our course, you bring the faculty with you. And so we have, it's really powerful. We have didactics and videos and simulation and standardized patient. And we have a simulation probably out of the 16 weeks, all but 3 weeks. We also have a mock trial in which we involve our law students, and they come in. We have a lawyer in town to talk about tort law and malpractice, and then we actually have a malpractice case that our learners have to be deposed as expert witnesses, get ready for the trial. We do it in a courtroom, and then our lawyer students practice their craft and be able to have a suit. And so that's really a powerful kind of piece of this, because we move from just culture, and Gwen teaches that for us, then we move to administrative reviews, and then we go to malpractice as other pieces. It demystifies that for students so they're not afraid of it, and it gets back to that risk management piece. If we talk about it and understand it and have risk management a part of this, it makes it easier. So we talk about Lewis Blackman. We watch the video. This is one of the most powerful things that we do. And thanks to Helen and the work that she's done for years in sharing Lewis's story. But it's a heart-wrenching story. And I tell our students that we watch it in class, that it's very emotional. And I haven't yet watched it after all these years without sobbing, because it's such a tragedy that we failed Lewis and we failed Helen and her family. So, but in this process, we watch it and we stop. And we say, what would you do? What's going on here? Now that you know team steps, how would you rewrite this story? What would be different about what we would do? So I can't tell you everything, and Helen's going to talk more about it, but there's one event in this story that makes my heart sink, because a nurse recognizes that something's not quite right with Lewis. And she goes out into the hall, and the premise is that people were thinking that he had gas and constipation. And when she returns back to Helen, she tells her, oh, it's just gas and constipation. Now this gets back to, what are the 3 things you're most worried about? Well, let me tell you, when you would get involved in interprofessional education, be ready to learn. I've learned something all the time. So for my physician colleagues, I have learned that they do have the 3, what are the most worried things that you have, so that you don't prematurely close on a diagnosis, that you keep open the doors until you rule out some things that you're worried about. So if we were worried about Lewis having constipation and diarrhea, he's not going to die today. But if we worry about a GI bleed, he is going to die today. And so we need to be able to say, what are the 3 things that matter? The other piece of this is what happened to that nurse when she went outside. Something hierarchical happened. We don't know. We will never know what happened. But that nurse's opinion was changed. Instead of using the cuss words and saying, I am concerned that this boy's blood pressure is dropping, his abdomen is tight, and he's diaphoretic. We need to get a flat plate of an abdomen to see what's going on here. We need to escalate this case. If that person did say, oh, honey, it's gas and constipation, say it again. The 2 challenge rule. And if again I was dismissed, you go above somebody, because it's not about me and you. It is about Lewis and saving him. The second thing is they were having trouble managing his pain. And the story unfolds that, he had chest surgery, but he was having abdominal pain and groin pain. It was down here. What's going on? You want learners to be curious and say, this don't make sense to me. This is not the picture I'm expecting. I need to do something different. So if I can't figure it out, who can help me? I can't get his pain under control, so who do I call? Call a pharmacist to come and look at these drugs with you, look at this kid with you. And we actually go through and we do James Reason's Swiss cheese model with this, and we look at all the places that the holes lined up. And in the end of this story, we look at what has happened and how we can keep this from happening again. Our students finish by doing a reflective paper about it, and they talk about how if I was a practitioner in this case, how I would rewrite this story. And so the last piece of that pharmacist being there, Ketorolac was the drug that he was given at an adult dose. And it was a black box warning drug 4 years before Lewis received it. And so a pharmacist would have known that if I didn't as a nurse. And they would have said, why is this kid on Ketorolac? This promotes GI bleeding. And all the symptoms that we're seeing make sense now all of a sudden. We're no longer blinded by gas and constipation. Helen will tell us more. But this case, because of her work, is out there for us to use and make our learners think differently about how to change the care that we're delivering to prevent Lewis and other configurations dying again. The saddest thing, and I know it is for Helen as well, is that there's someone dying now from a preventable harm that we're not catching because we're not paying attention and noticing what's happening. And we've got to stop that madness. So we use a Mayo's tool, and we do debriefing. And in this tool, we grade our students on teamwork and collaboration, not on clinical skills, because that's our focus, is teamwork and collaboration. There have been barriers. There will always be barriers. So is this important enough that you overcome the barriers? Or you just say, oh, well, we tried, we can't? Is that good enough as you say to another patient, I'm sorry, but your person died because we didn't? How can you fill in the blank? So it's an imperative. We have to do it. We have to figure it out. And grading, interesting, silly things happen in academia. We could not get past the curriculum committees to have a same syllabus or same grading scale. What? So we said, okay, forget it. We'll have 3 different ones, and you deal with the students because that's not going to be going well. And so we ended up being able to get to the same grading scale at least. But we got barriers that we ourselves are creating that we need to let go. And our students have actually found that because of this, one of my students, master students, did a study that their commitment to a common mission, meeting goals without compromising relationships, and they created a care team much better, including the patient and the team and the members and the others. So, understanding healthcare errors, this is us in that whole idea. I jumped ahead of myself. This is our courtroom case. It's really quite fascinating watching those law students sweat it out too, as they're trying to ask the right questions and the judge overruling them and all those pieces. So the single biggest problem in communication is the illusion that it has taken place. That is it. We have to somehow think differently about how we're communicating and check back and make sure you understood what I said. We saw that in the paper tearing exercise. Gwen was clear. She gave instructions. She expected every piece of paper in this room to be the same. And she was surprised when it wasn't. Not really, but the point is, from that point of view, the illusion is she communicated to you effectively. Why didn't you do what she asked? And it looked the same. It's because we're going through our frames, our mental references, and we're doing it from our point of view. One of the challenges that we have had is handoffs, because we know handoffs is a place that people have errors. So we thought, great, we can create a handoff exercise that will be powerful for our learners, and we're good. Let me just tell you, these 3 brilliant people designing this exercise, medicine, nursing, and pharmacy, it took us 3 years to get it right. We would do it, it would fail, we would do it, it would fail. Then all of a sudden, we realized the problem is we were so IPE focused that we were having nurses hand off to physicians and pharmacists. They don't do that in real life. And it doesn't even make sense. So then if we actually made them do what they did in practice, hand off to each professional, and then come back as a team and huddle around it, it worked. Ta-da, that works. So it took us, 3 years to figure out what we were doing wrong. So you won't be perfect at this, but you will have a team who's committed to keep you working at fixing it. We even thought about ditching the whole idea, right? Because we can't fix it, but finally we realized what we were doing wrong. We had a blind spot. So I'm going to tell you about Leslie and Henry. These are students that we had. And so Leslie, in nursing school, was working as a CNA. And in the CNA, she was in a room with a patient who was deteriorating. And they had called, the teams were rounding. So Henry was the first day on the first medical student on his first week of being rounding with the team. They had been in course together last semester. So he walks in the room and Leslie says, "Oh, hi, Henry, come here. Let me tell you about the patient." She does an S-bar. She hands off all the information. And the attendants and the rest of the team are like, what is happening? Because this is not what they would have expected. The new kid on the block being talked to by the nurse, who's a CNA and not even a nurse yet, about the patient and doing this beautiful handoff. That's what we need to have happening, right? That's it. So they were so excited that they could do that because they had been trained in how to do that. So let's watch this video, and I'm going to talk over it because I want to tell you the points about this. This is not just about catching the bus. All right, so you will notice that they're floating on an iceberg, and everybody's like chilling. Then do you notice that one little guy sees a shark coming, or a whale, whatever it is, and he's like, he made a little noise, and he alerted everybody. They had a plan. They didn't have to at that moment say, what are we going to do? We're going to get eaten. They had a plan. All we need to do is alert you. So here is another. Now this is about leadership. The leader recognizes that one in the team is in trouble. Everybody, come. We got to help. You know what to do. No one's having to say, do it this way. He's directing the code, if you imagine, to code the anteater. So, but the idea, again, is that they knew what to do. They had trained. Then this one is interesting because it's the smallest kid on the block, the newbie, the new nurse, who sees there's a danger in the patient care, alerts the team, and they went on their merry way. So everybody, you can stop it now, everybody is clear about what they're doing. Everybody is valued as a team member, and everybody has their role. So now, one other video where it didn't quite go like we had hoped. So this is a terrible video in terms of quality, but it's got a good point. So what's happening here is the ball is fumbled, and the other team gets it. And Parker does a beautiful 54-yard run in the wrong way. So the thing that's, you watch him here, like, awesome man. He's like, awesome, I did a run. This guy says, it was the wrong way, guy. You'll see his head fall down in shame. We do that in healthcare, don't we? I can't believe you did that. We shame and blame. He's like, I feel rotten. That was stupid. So watch him here, and you can see it one more time. This guy fumbles. He catches it. Now, the thing that's really powerful here is that his team members are blocking for him. And the other team is trying to tackle him, which they should be blocking. So the point is, sometimes our mental model falls in behind the leader without us saying, wait, are we going in the right direction? Is this what we need to be doing for this patient? Where is our voice to say, the momentum is going down the field 54 yards? How do we say, wait, stop him because we're wrong? We need to do something. Somebody should have tackled him and reset. So we don't want to tackle our coworkers, but we do want to be able to say, wait, I'm concerned. I'm uncomfortable. It's a patient safety issue, right? So in front of you, you have a piece of paper. This piece of paper, it has a grid and 2 dots and a plus sign. If you don't have one, then share it with others. But the point is, I want you to hold it. Now, you're going to have to listen to the instructions because you're going to wonder in a minute what to do. Hold it horizontally. Cover your left eye. Focus on the plus sign. Slowly bring it to your face until the dot on your right side disappears. You may have to do it a couple of times to get it right, get your rhythm. Cover your left eye, focus on the plus mark until the dot on the right side disappears. Go a little further, it reappears. Okay, this is your blind spot. It's where the optic nerve goes into the optic disc. It is truly a physiologic blind spot. So now do it one more time, but this time I want you to notice something. Notice that the dot goes away, but the grid does not. So look at it again. The grid stays in place. What is that about? That is about the brain adapting and expecting it to be a grid. I can extrapolate this to the way that we work in teams. I am blind to the way that you work and the expertise that you bring, and I fill in the gaps of what I think you're doing and why you're doing it with my mental model without really exploring how. So, ironically, we have blind spots in the way that we practice, and we can't uncover them unless we work in a team who hold us accountable to how we do that. And that is how we're able to uncover our blind spots and improve our practice. So this actually comes from the book that's out right now called Blind Spot, but it really does illustrate how good people who intend good still have blind spots. So I'm going to talk about some blind spots in interprofessional debriefing that we've done. So I'm just going to give you a couple of examples here. One of the cases that we do is a really complex case. It's Sarah Tomlin. It's a serotonin case. There's her name, comes from that, Sarah Tomlin. It actually is based upon Libby Zion, which is a 1982 sentinel case that was in medicine. And we wrote this case based upon that story. And so it's a young girl who comes in with an appendectomy, and she has an adverse event. I think she might actually die because she got a wrong drug. What happened is it pushed her over the edge in terms of the drugs that she had on board. So in the case, we have an embedded actor who has key information, and it's her friend, Susie. And so her parents are there, the mannequin is there, who's the patient, and Susie. And so the students know that there's going to be these players. And so Susie has really key information to this case. The key information is they were partying last night, she was drinking, and she also did meth, and she has been taking serotonin. No, she'd been taking the drug that, is the over-the-counter one, St. John's wort. She'd been taking St. John's wort because her boyfriend and her broke up. No one else in the room knows this information but the friend, because the mom thinks she doesn't do drugs and no one can pull it out. So the pharmacy student recognized we need to find out what happened last night because she's not responding how we think she should, and there may be drugs on board. And so she goes over to Susie and takes her away from the patient and talks about what's happening. And so the medical student who happened to assume lead, it could have been anybody, but he says, we don't care about that. I need you back over here for a huddle. Remember, we're grading them on team steps. So he pulls her back. Now, when we get to debriefing, I don't stop it. I let it go, and she gets worse, and things go on. We get to debriefing. And so I ask, instead of asking him why he did that, I turned to the pharmacy student, and I said, I'm curious, when this student asked you to come back to the team, what were you trying to get at? And she said, well, I was really interested in did they do anything last night, et cetera, et cetera. And I said, that's an interesting line of questioning. Why don't you ask me now, and I will assume that role. So yeah, she asked me, and I dumped out the information. And everybody on the team's like, oh, gosh, we thought it was sepsis. Now it's not. And so, but, and the medical student, to his credit, hit the table and said, I messed up. And I said, wait, you're operating in a team. It was not just you. So I went back to the pharmacy student and I said, you've been trained on team steps. You know the 2-challenge rule. You know the cuss words. I'm just curious why that didn't come into play. And she said, I deferred to the hierarchy of the leader. And I said, that is a wonderful example of the issues that we have. And how can we overcome that? Because if you had I said, let's do it now. And so they practiced it, and I said, and medical student what would you have done? And he would have listened because he also had been trained in team steps. So that illustrated it better than we could have talked about it all day long. And they won't ever forget that. Then secondly, I was in a professional group of practitioners, interprofessionally, and this diabetes, discharge, getting ready to go home. And a non-physician said about physicians, well, physicians don't spend any time with patients anyway. Oh, goodness. I'm like, I have to debrief this. It's not about diabetes, and it's not about this case at all, but we can't leave this on the table. We go to debriefing, and I come back, and instead of saying to the person, you don't even realize what you just said and how hurtful that can be in what you're saying, I said to the physicians in the room, so how did that make you feel? And they said, that really hurt because I feel like I spent a lot of time with patients. And my intent is to do just that. And the person then all of a sudden realized her blind spot, that she was operating around from her feeling like her mom didn't get the physician time that she needed. And so she put that frame in the middle of the simulation. But in actuality, it shows us that we do come at it from our frames, but we have to be careful because words matter. And what really happened is in the beginning when they were diagnosing this patient, trying to figure out what to do and stabilize her, the physicians had a huge role in that. They were doing the expertise that they had. But then when we moved down to discharge, the physician needed less a role and could rely on the team to do what they needed to do to get her safely discharged into care, to go home. So they were doing exactly what they needed to do, not less time. So why do we measure everybody else by our work? Because we might be collectively as nurses in the room 24/7, and the physicians come and go. They are doing exactly what they need to do for the team care of this patient. And when we begin to dismiss one profession or another because we're measuring by our measuring stick, we're doing an incredible disservice to what needs to happen to the care of the patient and the team even. So guard against that. This is Arlington Cemetery. John James is a colleague that we have that has done some examination of the data about eras, and his son died of a preventable era at 19 years old, Alex. And so what he has done here is said we probably have underreported, but his calculation reveals at least 450,000 people die from preventable harm every year. And that is how many grave sites there are in Arlington. I'm a visual learner, so it's really hard for me to wrap my head around a number. But when I see this and that we are filling Arlington Cemetery every year because the way we are training is not producing the outcomes we need. So it's not our healthcare systems, it's all of us. Because I've been teaching for years, and I am responsible for what my learners are doing or not doing in the practice that they assume. So I am committed to changing the way I teach because of that. So I think we have to think about that more carefully. It's easy to say, well, the healthcare systems, it is all of us. Because if I taught them differently, they would be different. So we have to do it differently. I know that these learners get into practice, and if they've been trained, they're running up against changes that are not yet there, but they can be part of the change. And we have lots of clinicians in the hospital who also are passionate about this and are changing and bringing about this culture change themselves. So eventually we're going to meet. But we can't if we don't start. And so we have to find champions on both sides of the fence to bring about a change in the way that we prepare reflective, collaborative, practice-ready practitioners. That comes out of that document that I showed you early on. And I thought that was a beautiful way to say it, right? We want to prepare great nurses, physicians, social work, etc. But we also need to prepare, on top of that, practice-ready people who are able to collaborate and be practice-ready. So Frederick Southwick here in Florida said, as an individual, I will make errors, but as a team, I am much less likely. That's reassuring, isn't it? He suffered medical errors, and so has his wife. Consider how we can invite all the team members to contribute. What are they most concerned about for this patient? Not my patient, not your patient, our patient. I'm trying to train our learners that everybody who arrives at UNC Hospital is our patient. Whether they come into us from the emergency room or through some other mechanism, they're our patient. They're not that floor's patient or that unit's patient, they're our patient. They came out of our community. What stands out for them? What have we not yet considered that might be a possibility? How do we have our voice and speak up? And listen, listen, listen. There's a reason we have 2 ears and 1 mouth. So Google learned from its quest to build the perfect team, which I think is pretty interesting, and this article is a free download as well. And so I wrote down my notes about what Google learned. They did this about 5 years ago. They had 50,000 employees. They looked at 180 teams. Think about what a rich database that is. And they had these hypotheses about what made a great team. They looked at, did experience mix matter? Socializing outside of work? Did the MBTI mix matter? Did they have similar hobbies? Did they clarity of goals matter? Did age matter? Management style, does that matter? Did they spend time on the team? How much time they spent on the team, did that matter? What was the things that mattered? So every hypothesis failed. Surprisingly, one cultural norm outweighed every other variable, psychological safety. So psychological safety describes a team climate characterized by interprofessional trust and mutual respect in which people are comfortable being themselves. So the success was about their experience, their emotional interaction, and their ability to really look at what they were doing. So as a team, isn't that interesting? Because we think we can design teams that are successful, but it's about, are we safe in that team? So it's very complicated. They were able to have complicated conversations and discussions of who we want to be and how our team makes a difference. And it really was this core variable of team success, was this idea. So what is our team design? And is it conscious team design or unconscious? Because you're designing a team, you either do it with purpose or it's being designed and you're not clear about what's happening. So joy in work is really important. And our ability to have healthy teams, healthy work environment, meet our goals, work-life balance, improving systems. Trust, respect, value, expertise. So Paul Batalden says every system is perfectly designed to get the results it gets. Think about that and the results that we're getting. If we're teaching precepting as we were taught, then we're preparing students for a healthcare system that no longer exists. So we have to transform healthcare from professional knowledge, which is important, to also include systems knowledge. We have to have individual learning, important, but also team learning. We have to move away from blaming culture to adjust culture. And we have to have discipline training that's focused about who you are as a professional, but we also have an interprofessional focus as well. There are resources on this slide deck, and I would point you to the Nexus. Has tons of resources, including tools for IPE. And I want to say thank you for engaging with me for this hour.